Good morning, everyone. Welcome to the Hindu Physicians International webinar series. My name is Dr. Adityanji, and I'm the president of HPI. At HPI, our mantra is Sharira Madhyam Khalu Dharma Sadhanam. Basically, body is your temple, both for the physicians and their patients. So we have to take care of our own bodies as well as our patients' bodies. Today is March 22nd, 2026, 10 a.m. Eastern Standard Time here in United States. Our distinguished speaker today is Dr. Shaila Bokkala-Pinninti, and she will be talking about Parkinson's disease, environmental exposure, prevention, and management. What is HPI? We are a faith-based medical charity by physicians of dharmic origin to serve the entire humanity. We have a self-governing board of directors with 5 members, and we are registered in the state of New York as a non-profit organization. We follow the Sanatan principles of Vasudhaiva Kutumbakam, Naraseva Narayan Seva. We believe in the divinity of every living creature. There are multitudes of faith-based medical charities. There are Christian medical charities like Médecins Sans Frontières. There are Jewish medical charities, but there are not very many Hindu medical charities. Most of Hindu physicians' organizations are actually Indian physicians' organizations that seem to be secular. So that was the reason we decided to start this platform for dharmic physicians, Hindu, Buddhist, Sikh, Jain, to have a platform for faith-based charity. And that is our board of director. I will not name them. We have an international advisory board. And lastly, we have an executive committee, young physicians who want to volunteer for the work of HPI are welcome to join our executive committee and take up a project. Our last volunteer was Dr. Dipali Desai, who is functioning as Director of Outreach for Dharma organizations. We have short-term and long-term objectives. Our immediate objectives is to do community seva activities worldwide, wherever Hindu physicians are, and raise some awareness about environmentalism and other issues. That's why we have this webinar series. But we have long-term goals also that we may not be pursuing immediately, but as the time comes by, all the long-term goals would be pursued. Our membership is free. There is a Google form on our website, so anyone can fill that form, whether you're a physician, surgeon, allied professionals, radiographers, nuclear medicine specialists, technologists, psychologists, social workers, even community volunteers can become members by filling up the form as volunteer. Membership is free. And then there's a form for community seva projects. We encourage physicians to do their own seva projects in a decentralized manner and just, give us the details so that we can certify this as a HPI seva project. We have a distinguished physician lecture series. And of course, today we have Dr. Shaila Bokkala-Pinninti. Those of you who saw this flyer, this was basically we had advertised this particular webinar. Dr. Pinninti is DO Ph.D. She has a Ph.D. in biochemistry from Osmania University in Hyderabad. She went to medical school in United States at UMDNJ School of Medicine in New Jersey. And she completed her neurology residency at Hahnemann University in Philadelphia in 2008. Currently, she is Chief of Neurology at Inspira Health System, and she is also Assistant Professor of Neurology at Cooper Medical School in New Jersey. So, as I said, our focus is on Seva. We try to do local Seva project. This is a small project done by our secretary, Dr. Rakesh Sharma, in conjunction with the Rotary Club of New York. So you see the HPI logo there. And of course, something actually related to that Rotary Club project. We have other Seva projects that we have done in the past, but I'm not going to go into that because we have covered those ones. So please, if you are based in United States, please donate and support to HPI. You can pay by PayPal or mail a check to our PO Box address. And we encourage everyone to do Seva projects in which you are the in charge. So you remain as in charge of that particular Seva project. So without further ado, I'm going to invite Dr. Shaila to deliver her lecture. She'll speak for 35 to 40 minutes, followed by question and answer sessions. Please have the platform.
Okay. Good morning, everybody, and thank you very much, Dr. Adityanji, for giving me this opportunity. I am actually speaking on behalf of VT Seva, which is it stands for Volunteering Together for Seva. It's been in United States and other countries in the West for the last 17 years. Can you hear me?
Yes, we
Yeah,
can
we
hear.
can hear you, but we cannot see your shared screen. I don't think you've shared it yet.
Okay. All right. I will share it right there. So anyway, this is the organization while I'm saving. It's volunteering together, and the activities include, educating the blind, the tribal people, as well as, can you see? Can you see
Yes.
the slides? Okay. So as well as raising funds for any kind of natural disasters, including floods or earthquakes. And also part of it is also developing and grooming young youth for future leaders. So in this particular thing, we've been focusing on health and wellness. We have about a presentation every other week, and this is our number 19. We also donate healthy snacks, including fresh fruit and nuts, every week to people with serious mental illness who also are underprivileged. And we've been donating this for about 34 weeks now, and we reached out to 1,300 individuals so far. So there are multiple ways of getting involved with this VT Seva, is volunteering your time in person or remotely, whichever works out for you. It's also helping in obtaining resources to help people and also spreading the word so that more people can be part of this. This has been started by His Holiness Dr. Chinnajir Swamiji. So how do you, I'm sorry, going the other way around. So this is one way of is to go to the website. You can choose an amount, whatever works out for you, and then you can write the check to Sanjeevani, and it will be written as fruit and nut donation. Thank you. So I'll start my topic with the Parkinson's disease. We all know that it's an eponym. It's named after Dr. James Parkinson, who was a British physician in the 1817. He was a very astute clinician, and he documented the symptoms of Parkinson's disease patients by just examining three of his patients, but three which he saw walking on the street. He actually documented this as an essay on the shaking palsy in 1817. He also called it as paralysis agitans. And he was the first one to distinguish resting tremors from action tremors or postural tremors. Now we call them as benign essential tremors. But 60 years later, actually, the eponym came in when Martin Charcot coined the term. As you can see here, he had a really very vivid and very clear and lucid description of the symptoms, which we still have, they're relevant, He says involuntary tremulous motion, decreased muscle power or strength, the trunk bends forward, which we call as a camptocormia, and then they have walking difficulty, running with a pace, like chasing their own center of gravity. And even the senses and intellects are compromised as it goes on. So a very clear description of Parkinson's disease patients. Coming to the prevalence, it is actually getting more with life expectancy increasing. It's 160 per 100,000, which is 20 per every 100,000. The age of onset varies. It's between 20 and 80 years, with a mean age somewhere between 55. Juvenile PD is an age of onset less than 20 years. This is rare, and this is pretty much very genetic. Young onset PD, on the other hand, is between 20 and 40. And here, Michael J. Fox was diagnosed when he was 29 years old. So his was a very young onset PD. So again, men, it's much more prevalent in men than women, with 1.5 times more in men than women. Age, of course, is a big risk factor. And as I mentioned, as the life expectancy is prolonged, so also the Parkinson's disease prevalence is increasing. So it is, we all know that it's a neurodegenerative condition. It belongs to these classes of a class of disease where the culprit is the alpha-synuclein. This is a protein, and they are referred to as synucleinopathies, along with Parkinson's disease, and there's a condition called multiple system atrophy and diffuse Lewy body dementia. So here, I mean, I know for the lab, not everything that shakes is PD, because you have two types of PD, which are tremor predominant and gait predominant. And one of the characteristic features of Parkinson's disease is very asymmetric when it initially presents. Later on, it can extend to the other side as well. So some of the notable personalities which we are familiar with Parkinson's disease, the first one, probably know that, is Muhammad Ali. He was a boxer. He was diagnosed in 1984. He probably took multiple hits with trauma and traumatic brain injury as well. President Bush in 2012, but apparently he actually sustained multiple infarcts, so it's actually vascular Parkinson's dementia. The third one is a singer, Neil Diamond. He still advocates for Parkinson's disease foundation. 2024, Brett Favre was diagnosed. He was a quarterback for Green Bay Packers, and I think 2 years after he retired, he was diagnosed with Parkinson's disease. Michael J. Fox, of course, was diagnosed 29. He still acts sometimes. He fairly had a prolonged career even after the diagnosis. 2015, he recently passed away, Jesse Jackson, Reverend Jesse Jackson. There was some issue about whether it was Parkinson's disease or a progressive supranuclear palsy. This is Brian, 2008. He was Brian Grant. He was a basketball player, a Hall of Fame basketball player. And we have Pope John Paul II, was diagnosed with Parkinson's disease, and he actually passed away 4 years after he was diagnosed. And you can see the asymmetry there in his face. The next one is Janet Reno, the first woman attorney general of United States. Robin Williams, of course, 2014. His wife had an autopsy, and they actually found Lewy bodies. So he was diagnosed with diffuse Lewy body dementia. Finney was a first American to win the Tour de France, and also won an Olympic medal. I think it's bronze Olympic medal. And the last one in this picture is Dave Parker. He was a Hall of Fame basketball player, also known as the Cobra. And he was diagnosed 2 years after he quit playing. So coming to the global burden, the direct and indirect costs of PD are astounding. 25 billion. These include Social Security payments, the lost income, and even caregiver cost as well. Not to mention the enormous amount of burden that it takes for the family or the caregiver, including financial implications. Of course, there is a huge emotional toll because it is neurodegenerative, and you see patients deteriorating gradually. Parkinson's disease is something, they lose their balance, they're more susceptible to falling. With that, they can get intertrochanteric fractures, cause hospitalizations, and severe handicap. They can also sustain subdural hematomas as well. And there's also associated dementia, which can manifest at any stage during the disease course. So that also becomes a huge burden. Coming to the causes, there's no single cause. Most of the majority of the Parkinson's cases, it's unknown, but there are several genes that have been identified, including the alpha-synuclein, and there's listed there as Parkin, UCHL, PON1, MDR1, SNCA, PINK1, and LRRK2. And this list grows on as more genes are identified. But the key thing I want to emphasize today is about the environmental exposure to pesticides, the air pollution, and believe it or not, we are living in the air where the pollutants are so rampant in the air we breathe, the water we drink, and also the soil we produce grains, vegetables, and fruits from. So this actually has been a key factor currently, and Usually in the past, it used to be attributed to age, but I don't think age alone is a factor. So exposure to pesticides plays a significant role. In the 1980s, actually, the way it was discovered in the Bay Area was MPTP, was a neurotoxin that caused reversible damage. Unfortunately, this was found as a contaminant in synthetic heroin when they were using drugs. So what happens with the mechanism? So alpha-synuclein is there in everyone. In Parkinson's disease, what happens is there's misfolding of the protein. So it does not go through the regular degradation pathway. And what happens is it aggregates. So these aggregates of protein form these Lewy bodies. And you can see on autopsy, the pathology report. So what happens when the Lewy bodies accumulate? There is pro-inflammatory surge and causing neuronal damage. The inflammation then compromises the blood-brain barrier and makes it permeable to all kinds of toxins, causing further damage. The most neurons that are actually susceptible to this are the dopamine-producing neurons in the substantia nigra. So they're not making adequate amounts of dopamine, and that's why you supplement them with the levodopa. There are mechanisms beyond dopaminergic damage. Initially, previously they used to think it was just the dopaminergic neuron damage, but I think it's more than that. So like I said, pesticide exposure is becoming almost like a pandemic, and I don't think Parkinson's disease can just be attributed to aging alone. So lifestyle changes, environmental, so more of sedentary lifestyle and fast food culture also plays a key role. Pesticides and microbiome influence the initiation and progression of PD independently. And I will talk to you about that because there's a gut-brain axis that plays an important role in the PD pathology. So exposure to pesticides, what happens, it increases the alterations in some of these genes which are susceptible to. So this is where epigenetics plays a role. Particularly these particular genes, GST, PON1, MDR1, and SNCA, are easily susceptible to pesticide exposure and causes alteration in the gene expression. So however, we do not know how long you need to be exposed or what exactly the mechanism is. And that's being unraveled as more research goes into it. So we come to the gut-brain axis. So we are what we eat. So our intestinal bacteria are likely to be involved in the formation of these intestinal alpha-synuclein fibrils that are seen in the intestinal neural practice. So there are these receptors, toll-like receptors, which actually confer innate immunity. And they confer this immunity by recognizing these motifs on the microorganisms. Now, any kind of an imbalance in these microorganisms causes the dysregulation in their signaling, and that's what's implicated in the alpha-synucleopathy, which is seen in PD. Now, the enteroendocrine cells have a direct synapse with the vagal afferents, and we know that vagal nucleus has synaptic pathways to the substantia nigra and the striatum. So the treatment is just dietary modification. So you probably would encourage eating more yogurt or more fermented products, which will replenish your gut microbia. But if refractory, then there are probiotics and fecal microbial transplants as well. So the significant driver for this is now implicated as they contributed to PD pathogenesis. They've done a meta-analysis of intestinal microbiota in PD involving 5 countries. And what they have indicated is these mucin-degrading Akkermansia is the name of the bacteria, which is increased. And then the bacteria that actually produces short-chain fatty acids have decreased in PD. So both these dysbiotic mechanisms actually increase the intestinal permeability. So this is a parallel mechanism. In the gut, you have the intestinal permeability. In the brain, you also have the blood-brain barrier is compromised. So what happens when the gut becomes leaky? This facilitates exposure of the intestinal neural plexus to toxins such as lipopolysaccharide, pesticides, which in turn leads to abnormal aggregation of the synuclein fibrils. And then also the decreased small chain fatty acid production downregulates the regulatory T cells and suppresses the neuronal inflammation. Coming to PD in Indian subcontinent, the research within India actually showed that hospital-based studies for some reason can be skewed. They are not really reflect the exact prevalence when compared to broader community surveys. So chemical exposure and well water, which is still being used in the rural and countryside, I guess, causes an increased risk of developing PD. So drinking water alone is like 7.6 times fold higher risk, and agricultural runoff or natural contaminants probably cause that. The air pollution is rapidly increasing in India. We know that in Delhi, they say that living in Delhi is equal to tantamount to smoking about 2 packs of cigarettes daily, and Hyderabad is catching up, I guess. So also the other cities, I'm sure. So high levels of this fine particulate matter and the traffic related are linking to the rising PD incidence. These particles, what they get so minute, they can bypass the blood-brain barrier because they use the nasal epithelium, triggering the neuroinflammation. Now, pesticides used in Indian agriculture, most of them is organophosphates, organophosphorus compounds. They are also implicated in Parkinson's disease. And we are very familiar that toxins such as paraquat and chlorpyrifos have been shown to double the risk of PD damaging dopamine-producing neurons. Of course, the heavy metals, there's no strict regulation there, and you have lead, mercury, but particularly manganese is involved. And this is from industrial work or environmental pollution is leading to neuronal loss, and then, of course, leading to the aggregates of the protein in the brain, which do not go through the degradation pathways. How do we mitigate them? So several lifestyle and household changes can help reduce. First thing is water filtration, high quality water filter, especially if people are in the live closer to the agriculture areas where pesticides are used. Food safety, again, switch to organic produce. This is easier said than done, but the easier way to do is to just rinse all the fruits and vegetables before consumption. Air quality management, of course, limit outdoor activities on a high pollution day and consider high efficiency purifiers, air purifiers to filter indoors to reduce exposure. Occupational protection, this can be done to providing masks, gloves, suits for the workers in the agriculture industry or factories where they work. But the gear alone is not completely make them completely immune, I guess. So lifestyle buffers is dietary choices. Apparently, consuming caffeinated coffee or tea has been shown to have a protective effect for Parkinson's disease. And physical activity, regular aerobic exercise like brisk walking, treadmill, can help maintain brain neuroplasticity and may actually delay the progression of motor symptoms, even if you're susceptible to PD. So the clinical feature is essentially divided into motor and non-motor symptoms. Sometimes the non-motor symptoms can manifest prior to the motor symptoms. But then motor symptoms are 4 cardinal features, which is resting tremors, otherwise known as the pill rolling tremor. We have the rigidity, you have bradykinesia or akinesia, and then postural instability. The other motor symptoms include, decreased facial expression or mask-like expression, which is called as a hypomimia, decreased volume, we call that as hypophonia, and festinating or shuffling gait, drooling, siluria, decreased blinking, which often causes dryness in the eyes as well, and difficulty initiating the gait, and camptocormia as the disease progresses, where the body is bent forward and then leaning towards one side, named after the Leaning Tower of Pisa. And the words run together and causes almost like a disorthric speech. A lot of times it is diagnosed as, maybe a TIA or a CVA2. The other thing is if you ask patients from history, they have micrographia. They say that the handwriting is getting smaller and sloppier as well. They do have decreased grip and dexterity as well. And walking is the main thing. They almost walk as if they're running because they chase their own center of gravity, and that's why they're susceptible to falls. So that's how the stoop posture looks like. That's called camptocormia. And then you have the Leaning Tower of Pisa sign. Even while seated, they tend to lean towards one side. So the non-motor features are pretty much, they can proceed, as I said, they can have personality changes. Somebody who is very balanced and quiet can become very aggressive with bursts of anger. They have impulse control problems. This is usually referred as pathological gambling or punting. Changes in cognition, they do have cognitive impairment. They have anosmia, loss of smell, and visual hallucinations. And these are very vivid and formed visual hallucinations, which can be extremely disturbing to the patient. Fatigue, daytime somnolence, and pain as well. In fact, sometimes pain can be the initial symptom, and they're referred to orthopedics thinking that there is some shoulder problem or a hip problem, and then eventually they're referred to neurology. when the workup is non-yielding. Dyskinesias are often seen with PD patients. They are abnormal involuntary movements of extremities, neck, and head. They can occur along with dystonia, and both of which can make the patient very dysfunctional, also very painful. But they resolve spontaneously, they're transient, but they can be very debilitating and painful as well. Sometimes you can see even dyskinesias as the side effect of levodopa as well, and amantadine is used for these painful dyskinesias. Dystonia is referred as a focal rigidity, again causing abnormal posture. It could be neck, face, mouth. And when it affects the arms or the legs, then it's actually very disabling. They can't walk, and they're pretty much bound until it resolves. If the mouth is involved and there's dysphagia, or even they can get aphasic and not speak, getting the medication into them gets challenging when you have oral buccal dystonia, because it's like you get the medication, you can relieve them, but getting the medication is challenging. So diagnosis is, I said, it is pretty much clinical diagnosis, diagnosed by neurologists. It can be very difficult and challenging in the beginning because the symptoms can be very, very subtle. So often it's not unusual to be missed. And then, of course, when the symptoms progress, it's a no-brainer, then anybody can diagnose, of course. CT and MRI studies are pretty unrevealing. They do it to exclude other etiology, but you really don't need CT or MRI studies. DAT scan especially is useful, especially when you have very subtle symptoms and you can't distinguish between essential tremor and Parkinson's disease. It is useful. And of course, PET scan with a radioisotope is also used. So this is a PET scan using fluorinated dopamine, and you see on the left the healthy control. I mean, it's not so black and white, of course, in real life, but you see how decreased there is in the PD patient. DAT scan is, again, it is dopamine transporter scan, and you can see again in the striatum, very well, lights up very well, and very sparsely in the abnormal scan. Now, sleep disorder is 98% of the PD patients often have, and actually RBD, which is REM sleep behavioral disorder, is a harbinger. You can often see that before you manifest any of those symptoms, even the non-motor symptoms, they can have REM sleep behavioral disorder. So most of the PD patients may not have RBD, but a lot of them have. Excessive daytime sleepiness is seen, nocturnal insomnia, sleep disorder breathing, excessive snoring, and restless leg syndrome. The REM sleep behavioral disorder actually can precede few years before the onset of PD symptoms. If you see RBD in an elderly, you should have a high suspicion for PD symptoms to follow. They enact their dreams and often hurt themselves or their partners in sleep. They often fall out of bed as well. And, if they're elderly, then sustain fractures. Now, the differential diagnosis with PD would be, secondary Parkinsonism. Most of the times it is typical antipsychotics. The vascular PD, you can have a bout of these small lacunar infarcts, and the cumulative effect is you demonstrate Parkinsonian symptoms. The multiple system atrophy is there, and diffuse Lewy body dementia. And one economy disease we don't have anymore. It was originally in the 1920s, I believe, from a streptococcal infection, but it was almost like an epidemic. So only multiple system atrophy and diffuse Lewy body dementia, the synucleopathies, along with PD. What is the treatment? Believe it or not, we have just the levodopa. I think it was in the 1920s or 30s. Since then, we have had modification of that, but we really don't have anything better to offer. Dopamine agonists are there, ropinirole and pramipexole. Usually, that's what they start off with, and then eventually, start them on carbidopa, levodopa. But you do have monoamine oxidase inhibitors, selageline or rasagiline. You can use any of these combinations, and there are combinations pills as well. Then there's COMT inhibitors, entacapone and talcapone, and of course the good old carbidopa, levodopa. And amantadine is used mainly for the dyskinesias. And of course, we have the deep brain stimulation as well. So here, the deep brain stimulation is you meet certain criteria for DBS. The patient actually will not be a candidate if they have cognitive impairment. They should have a good response to carbidopa, levodopa, and then they would be a candidate for DBS. DBS, usually the target is STN, subthalamic nucleus, is the best one, and it is usually bilateral. And patients do pretty well. It is invasive. So the recent research has shown that it is not invasive with just ultrasound, targeted ultrasound. They still can stimulate the subthalamic nucleus and produce similar effects to DBS without any, intervening electrode placement and intervention. Then there's stem cell transplantation. This has not really yielded much successful results because when they transplanted the stem cells into the PD patients, they acquired the PD pathology. So it's still in its infancy, a long way to go. For REM sleep disorder, actually, Klonopin works very well, suppresses REM, so they don't manifest those symptoms. And for these vivid hallucinations, pimavanserin is good, but you can use even quetiapine as well. But the problem is quetiapine is antagonist. It is a dopamine depleter as well. So one comment is, I just wanted to say only because it was Dr. Oliver Sacks, the British neurologist, wrote a book on it, but it was referred to as encephalitis lethargica, also known as von Economo disease, named after, again, the eponym after the person who discovered. So again, this was characterized by severe lethargy, somnolence, fever, and Parkinsonian features, and they had no clue what it was, but later they figured out that it was actually from an infection, streptococcal, they thought. People were actually isolated in hospitals, and Oliver Sacks actually wrote a book in 1973 based on his clinical observations of patients in the 1960s. And then there's a movie made in the 1990s, Awakenings. So levodopa was actually revolutionized the treatment because these people who were asleep and pretty much catatonic woke up with this L-Dopa, which was an experimental drug then. So multiple system atrophy, as the name indicates, it involves multiple, whereas Parkinson's disease is pretty much substantia nigra and the striatum. Here you have the striatum, substantia nigra, and also the oligopontine cerebellar system. Initially, it used to be called as three different ones. There was Scheidegger, which was predominantly autonomic. There was SNPD, which was substantia nigra degeneration, SND. And then it was also oligopontine cerebellar degeneration, which is predominantly cerebellar symptoms. Now we classify them as MSAP and MSAC. So MSAP is predominantly Parkinsonian symptoms and MSAC is cerebellar. So again, this is as well progressive, but it's adult manifest. If you have a younger onset, then by all purposes, then you can conclude that this is Parkinson's disease if it's a younger onset. This is usually adult, middle age. The symptoms of Parkinsonism is seen along with significant autonomic symptoms. There's cerebellar dysfunction as well, which you don't see that much in Parkinson's patients. So it is symmetric as opposed to Parkinson's disease, which is asymmetric, and resting tremor is uncommon. They don't have a good response to carbidopa, levodopa. Some of the other features are orthostatic hypotension. You have urinary incontinence, erectile dysfunction, poor lacrimation, salivation, constipation, and they do have a very loud inspiratory stridor. They do have atherosclerosis too, sleep apnea, and gait imbalance, and then of course the characteristic Pisa sign. So the autonomic symptoms are usually treated. Orthostatic hypotension is very, very common. It is treated with fluorocortisone or midodrine. Sometimes you can use a combination, but they have another drug that they came up with, orthodropa or norethindrone. That works very well if these two fail. Urinary incontinence with oxybutynin and methamphetamine. Dopamine therapy gives moderate improvement. So if you try and you can get a therapeutic diagnosis as well. If they respond very well, chances are that it may be PD. And they do have associated dementia like PD, and the choice of medication for this is rivastigmine. Again, it does not really cure the dementia, it just prolongs the progression. Secondary Parkinsonism is, as I mentioned, antipsychotic medications. The typical antipsychotics are not that commonly used, but Haldol, chlorpromazine, fluphenazine, and thorazine are used. Some of the atypical antipsychotics also cause mild secondary Parkinsonism, and usually the treatment is to either decrease the dose or stop the offending agent. But I know it's hard if they're bipolar disorder, they're very well controlled. So sometimes we may just have to add levodopa to their medication regimen. Vascular PD, as referred to, is multiple hits of these strokes causing small lacunar infarcts, and cumulatively they manifest Parkinsonian symptoms, and this is often seen actually on MRI. So you want to rule out vascular PD, and that's where MRI comes in handy. Symptoms are again similar to Parkinson's disease. The diffuse Lewy body dementia is irreversible progressive neurodegenerative condition. They do have Parkinsonian features. They do have the rigidity and the tremor as well. But the characteristic of this condition is they have TIA-like symptoms. They often can have, transient one-sided weakness, numbness, tingling, or a sudden onset of aphasia. And often MRI is negative, and they recover without any permanent deficits. And this dementia is the second most common to Alzheimer's dementia. The What is bothersome to the patient more than any other symptoms is these visual hallucinations. They're very vivid, very formed. They could see animals, they could see children. Often people are, there are intruders in their house when there's nobody, but they are so real and lifelike that they believe in them, which is actually bothersome to the patient, but also to the caregiver. Again, REM sleep behavioral disorder is a harbinger for this condition more than PD. The life expectancy is only 5 to 8 years once the symptoms are manifested. And Robin Williams actually had a brain autopsy, and they found Lewy bodies, and apparently he had dementia prior to that. So that's what he was eventually diagnosed with. And I would like to actually pay tribute to my sister-in-law, my husband Narasimha's sister. This is what she was on the left. She was diagnosed with Parkinson's disease in her 40s. And she was a fighter, actually. She had BBS. She did very well. She continued to work. But you can see the progression. This is one of the pictures in the middle is where she had the dyskinesias, dystonia, and patients often are like writhing in pain. It's very disconcerting to see them. She actually passed away not from Parkinson's disease, but from multifocal motor neuropathy. She, had a double whammy, and they say life, license please are not mutually exclusive, is what my mentor used to say, and that's often the case. So she did not pass away from PD. She did very well, but unfortunately, she had multifocal motor neuropathy, and then became, bed-bound, wheelchair-bound, and sadly passed away. So I can take any questions.
Badrinath. Yeah, so I have a few questions, which is okay, right? 2-3 questions I have.
Sure, absolutely.
Right. Okay. The first thing is, is there any kind of a test we could do early on, right? During as part of physical or something, I'm not sure, the mandated either by our insurance or, right, something we could do early on, right? And will that, anything we could do? That's my first question.
So genetic testing. Oh, I'm sorry. You're going to go with the second question?
No. Why don't you finish your answer?
Question by question, otherwise there will be confusion. So stick to one question at a time.
Okay.
Sure, yeah, exactly, yeah.
So genetic testing is available, but unfortunately there are too many genes. It's not covered by the insurance. It's like almost going like a wild goose chase. I mean, what are you going to test for the entire panel? So genetic testing is no longer. But if you have a strong family history, or if you have like a young onset Parkinson's disease in any of even your distant family, then you can go for the genetic testing. Particularly the genes narrow down, right? The genotypes narrow down if it's a young onset one. You can go ahead and test for that one. But otherwise, it's pretty much initial onset of the symptoms is when you do it. But if you're had history of like tiny TIAs or CVAs, then I think the best thing is to go ahead and get the MRI and see what the burden is, the lesion burden or the infarct burden. And based on that, you can, predict. But if somebody has manifestation of any of these symptoms, like, REM sleep behavioral disorder, where they're acting out their dreams, then you have to have a high index of suspicion.
Okay, thank you. Yeah. I'll pause here. Maybe other people have questions, and then I'll come back. Actually, right? Yeah,
Sure.
Anyone else who has question, please go ahead and ask the question. Otherwise, we'll give Dr. Nath another chance. Okay, Dr. Nath, you can go for your
Yeah,
second.
I'm not Dr. Nath. I'm Badrinath, actually. I wasn't able to change my name. I'm not a doctor at all, but yeah, I'm Badrinath. So the other thing, right? I know you mentioned, maybe I missed for first couple of slides regarding taking organic food, those kind of things, right? Which are less out of control. I mean, nowadays, I don't know whom to trust or who not to trust, right? From that perspective. Okay. I'm just wondering, anything that is, I mean, again, maybe I want to mention the Bhagavad Gita, right? Reading something like that, I mean, chanting or right continuously engaged in those kind of things, will it help to prevent some of these diseases? And Dr. Gara?
So definitely chanting, yoga, all those can decrease the stress. I haven't seen any literature saying that it would reduce the risk of PD, but stress in itself, maybe, it certainly can address your stress, I guess. I'm not familiar. I don't know. I'm not familiar with any literature about the chances of reducing PD or any of these conditions by chanting Bhagavad Gita or any of the scriptures.
Thank
Any
you, and that's
questions from anyone else?
Hi.
Yes, Dr. Khandelwal, please go ahead.
Have you seen increased incidence of Parkinson's disease in a patient who had COVID infection?
I have not seen, but COVID certainly causes strokes. They can be asymptomatic during the pandemic. Actually, I kind of ordered MRI even on asymptomatic patients. The whole thing, the mechanism is there's a huge cytokine surge, pro-inflammatory cytokine surge, and these can definitely cause. So, and not only cerebral infarcts, but also MIs as well. So indirectly, yes, because then you have, the burden of infarcts. If you have a lot more, then you are susceptible to having PD, yes, but not a direct per se.
Okay, thank you.
Anyone else with a question? Please go ahead. Just unmute yourself and ask the question directly. Looks like no one else has a question, so I might as well ask you a question, Shaila.
Okay, Dr. Adishanji.
So specifically for psychosis in Parkinson's disease, when we did not have an FDA-approved treatment, we used quetiapine or clozapine, which you did mention.
Mhm.
Now, of course, you have pimavanserin. But I was going to ask you, there's a new medication that has been approved for treatment of schizophrenia, which does not work through the dopaminergic mechanism, and it is Cobenfy. Although it is not FDA approved for psychotic symptoms in Parkinson's disease, would you venture to use it in your practice because it does not touch the dopaminergic system?
Oh, absolutely, absolutely. Because we don't have many drugs. We don't want many in the armamentarium. So yeah, anything that can help them, because not many people respond to pimavanserin either. So yeah, additional tools in the armamentarium will only help the patients. Absolutely. And especially if it's not going through the dopamine, then I'm not depleting anything and I feel more comfortable. Absolutely.
Okay. Anyone else has question for Dr. Shaila?
Yes, hi, this is Dr. Dubey. I'm a psychiatrist. I actually read some dancing classes were arranged for elderly people with Parkinson's, and there was some benefit with dancing. Have you heard of anything like that?
Yes, actually, this was not dance, but the way it was discovered was there was this Parkinson's disease patient who did tandem bicycling with his daughter, and then his symptoms had improved. So they wondered what it was, and then he was regularly going like twice a day or once a day, whatever he was doing, and there was a remarkable improvement to the point that he could even decrease the uh, carbidopa levodopa intake. So that's how they. In fact, I tell every patient. You can do the tandem walk, you can get onto the stationary bicycle because then the risk of falling. But what you could do is a portable pedaling device. So it's a portable pedaling device you get on the internet. It's like $40, $50. It has pedals. And then you can do that. And there's no risk of falling because you're sitting on a couch or you're sitting on a bed and then you do that. So you do that 5, 6 times. My sister-in-law did that, actually bought one for her. So 6 times, 7 times a day, even if it's 10 minutes, it's okay. And the same thing, you put it on the table, you can use it for your hands as well. So that's where this came off as that. Then they extrapolated it to that, hey, how about dance lessons? Because it's it motivates them. I mean, motivates them even like, want to do something, motivates them to do something. It's group dance. So this is where they're, and they have found out that actually they can stimulate the remaining neurons, functional dopaminergic neurons, to make more dopamine. Yes, it does help. Even Tai Chi helps as well.
Oh, wow. There's another question I have about the newer medications coming, like Nuplazid,
Yeah.
Pimavanserin for
Yeah,
psychosis.
Nuplazid is pimavanserin. Yeah.
Yeah.
Yeah, yeah.
Mhm.
How is your experience with those medications, the newer ones?
So I kind of had about 70-30% in my practice, not literature, but 70% of them did well. They're significant hallucinations, like, seeing all kinds of things at night or daytime, but 30% did not have much luck. And then I had to go back to actually quetiapine.
Oh,
Um,
okay.
yeah, so, and I think pretty much the other neurologists who I spoke to had the same thing, 60,
Okay.
70%. It's not like, okay, it's the be all and end all kind of a thing, or,
And what about the use of antidepressant or anti-anxiety? What would you prefer? Is like SSRI, like if a
yes.
person
Yeah,
feels
SSRIs, Zoloft works very well for depression.
okay, okay,
Yeah.
very. Thank you. Thank you very much. It was
Eh,
really nice
Excuse
presentation.
me, excuse me. I'm Dr. Neena Agarwal from India. Can I have
Sure,
a
please go ahead
question?
and ask your question, Dr. Neena Agrawal. Please go ahead.
Yeah, I wanted to know that recently an article has come from Japan, 10 days back approximately, that
Mhm.
they have okayed the stem cell transplantation into brain for Parkinsonism and heart failure. And it has already been given level 3 trial, and it will be in the market after say in summer, June, I think June 2026.
Okay, it'll be in the market in Japan and India. I don't think in
No, not
US,
in India, in Japan.
in Japan. Yeah, no, in US,
I went through an article.
yeah, the one that I mentioned in the US was like almost 10, 12, yeah, 12 years ago, I think, where they actually did this
Yeah.
stem cell transplant, and then the newly transplanted cells also acquired PD pathology, so they did not go any further with that. But in India, actually, they keep saying that they have, especially in Mumbai. My sister-in-law toyed with the idea of going there, but I think it's not. I mean, I don't think I don't think I didn't do any research there, but I don't think I think they're false claims, but I could be wrong. But this was actually almost 10 years ago.
Or not 10
Mumbai.
years ago. It's only 10 days back.
No, but there were
They
some
given.
physicians who were proclaiming that they could cure with the stem cell transplant in Mumbai.
Yeah.
I don't know.
Not in Mumbai. This was an article from
No, this is
Japan.
from Japan, I
Yes, in
know.
Mumbai, they are claiming. There are many people in Bangalore and Mumbai claiming about it.
Correct.
But I'm not very sure about them. But
Mhm.
this one from Japan, they are telling that it has been given, it's in phase 4 trial, and green signal has been given by the Japan government
Mhm.
for its
Oh,
sale
great.
by some pharmaceutical company.
Great. I mean, if it works, it will really help a lot of the
That will be
population,
the,
right?
yeah, that's true.
Any more questions? People who have not asked any questions, they may have the opportunity to ask.
I have a quick question. I'm so sorry. Thank you for the nice talk. But as a PCP, we have patients come in asking, do I have Parkinson's? And, basically they're just having tremors at that moment, and they're concerned. So without having to make a referral to a neurologist, I mean, the only things I know to check is like a cogwheel rigidity, fascinating gait, and, these um, viewer biased test. How do you suggest a PCP should proceed with that? I mean, is there any other way to help these patients?
Sure, yeah. The PCP on examination, if you find even any subtle symptoms that you have a suspicion, then I would refer to a neurologist. Now, only tremors are the presentation, and those tremors are not seen at rest, and they're just postural or action tremors. Then, for all intents and purposes, it could be just the essential tremor. And you can even start them on propranolol. And if the tremors dampen, now it's not a realistic expectation to expect that the tremors will be completely controlled. Even essential tremors, that's not a realistic expectation for 100% control, but 70-80% control with medications is a realistic expectation. So if you put them on propranolol trial and they do well, then you have an answer. But if you think that in your mind, if you think that there is a slightest suspicion, then I would get a neurologist involvement as well, just to make sure that they get a complete exam. Because like I said, when it initially presents, it's so subtle. My sister-in-law, for instance, had just pain. Pain can be the sole manifestation. She went to 2 or 3 orthopedic physicians before she was referred to a neurologist. So, and I have seen patients who come going to different, orthopedic physicians and come to me. Eventually, then you get diagnosed. So, like I said, it's a very subtle manifestation initially. I mean, as symptoms progress, anyone can diagnose, of course, but it really, that's why it should take an astute clinician to actually pick up the nuances, the subtleties.
Yeah, interesting. Thank you.
You're welcome.
Any more questions?
Yes, there is one more question from Dr. Neena Agarwal.
Please go ahead.
I wanted to know about the recent monoclonal antibody, pranazumab, something like that.
Mm-hmm.
Does it work?
You know what? It's not used in the US. So I don't know.
It's not in market. It's in phase 4 trial.
I know. I didn't get a chance to look on that, but yeah. Phase 4 trial,
Okay.
where? Is it in the US?
I think it's going on in the US itself.
I'm not aware of that. The monoclonal antibody.
Okay.
It can't be phase 4 trial. Phase 4 trials are
Phase 4 trial.
approval.
They have
They are
entered for phase
post-approval.
4 trial.
Yeah, they would be. Yeah.
It can't be phase 4.
Yeah, it can be,
Okay.
Well,
Okay.
if there are no more questions, my profuse thanks to Dr. Shaila Bokkala-Pinninti for very informative lecture. We are really grateful to you. And I did not know the personal angle that a family member was involved, and so that humanizes the presentation. But the take-home message is that with the increasing environmental exposure, we all need to be aware about preventing the kind of exposure. People are living longer and having more chemical exposure. So although the genetics may not be so clear, but at least the environmental factors are under control, or at least partial control. So everyone should be aware of that. Thank you very much indeed. Again, Hindu Physicians International encourages physicians of dharmic origin to come on our platform and also do some community seva projects in your own community. Wherever you are located, we encourage you. We don't take control. Just fill up our community seva project form and we'll give you a certification for your seva project. Lastly, the physicians who are based in United States, we encourage you to go on our website. There's a PayPal link. If you want to donate, please support us because we do need your support for our charitable activities. And lastly, one of the members in the audience is Dr. Shivam Dubey. Dr. Shivam Dubey is a practicing psychiatrist in Orlando, in Florida, and he is going to be our next speaker on Sunday, April the 5th. Since he is present here, I may make this announcement binding him to his presentation. So
Thank
thank
you, sir.
you.
Thank you very much. Yeah, I'm really honored to present in front of all of you. And thank you for inviting me. The topic of my talk is the half education. If you give me 1 minute, I can tell you a little bit about it.
No, 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 no. Don't let the cat out
Okay.
of the bag. Don't let the cat out of the bag. Let people come and join in 2 weeks' time. But we are very, very pleased. And thank you to all the people who participated in this webinar. We hope that you keep on continuing to come for the webinars. And if anyone is interested in speaking, please get in touch with me. Again, we encourage seva projects in your community under dharmic banner of Hindu Physicians International. Thank you very much indeed, and we shall be ending the seminar now.
Thank you very much, Dr. Adhiyanji, and thank you very much for the panel attending.